To complement Dr. Brower's talk, our next speaker will be talking about the rehab approach for CP. Our next speaker is Dr. Mai No. Dr. No is a pediatric physical medicine and rehab specialist here at UCSF, Benioff Children's Hospitals. She completed her residency in pediatrics at UCSF and then physical medicine and rehab residency at UCLA. She has special interest in TBI, CP, and spina bifida. And at UCSF, she is the medical director of a pediatric physical medicine and rehab program at Benioff Children's Hospital, Oakland. Welcome, Dr. Mai.
Oh, great. They pulled up my slide presenter's view because I have a lot of slides. Thanks, Selena, for my introduction. So those who know me know that I really don't like public talking, but I think it's a little bit worth it because at least today in person I get to see my extended work family and some of my the crew from CCS counties. My Alameda County people are here, and then if you're from other counties and we don't really know each other by face, please come introduce yourself. So, no disclosures. Okay, so before I get straight into CP, I wanted to share this sort of mission statement about my specialty. One of the leaders in our field, Dr. Deb Gabler, helped put together the statement for an envisioned future of pediatric rehabilitation medicine. So it reads, in the future, the pediatric physiatrist is recognized as the essential physician expert for children and youth with acquired and congenital disabilities, with the main purpose to optimize function and life transitions across the care continuum and into the community. I just love how nice it makes my job sound. Here are my broad learning objectives. We're going to discuss the definition and diagnosis of CP, and then describe the clinical features and classification, and then hone in on the current rehab management and treatment. CP is easily the most common condition I see in my rehab clinic. So a typical referral would be a 2-year-old male with frequent falling. On history, he took his first steps at 18 months, but still has poor balance and frequent falling. And most of the time, I can just provide reassurance. However, sometimes it can be the first presentation of a true issue. So for this patient, there was a negative history of any prenatal events or postnatal complications. Neurology workup already included an MRI of the brain, which showed periventricular leukomalacia, so that's a good hint. And then on exam, he had normal upper extremity tone, but then spastic lower extremities. So he was tight at his hip adductors, knee flexors, and plantar flexors. And then his posture looks something like this picture, which is consistent with a diagnosis of spastic diplegic CP. More and more, we strive for earlier diagnosis to help patients and families get plugged into appropriate resources as soon as possible. We rely on our pediatricians to refer early based on clinical clues such as poor feeding or growth, paucity of movement during the newborn period, delayed milestones such as not sitting by 9 months, abnormal tone, which may be reported as a baby who rolls really early or is a good stander but is up on his toes. So these are the kids that sometimes the parents report as being really precocious, but then that raises a red flag for us. Sometimes you notice primitive reflexes or like really early handedness way before 2 years of age, or just general abnormal coordination. A lot of you in the audience will recognize this primitive reflex. It's the ATNR, or asymmetric tonic neck reflex, or fencing reflex. In typical development, this reflex goes away at around 4 to 6 months when the babies learn to roll, because if you just imagine that arm keeps sticking out there and that gets in the way of them trying to roll. But in CP, we see this reflex persist for a really long time. Like some of my more low functioning teenage patients will still have this fencing reflex. So back to our case. At this point with our 2-year-old boy, I can make the diagnosis of CP, which is defined as a non-progressive injury to an immature brain that impairs motor control. I feel like that's the fewest words that I can use to describe CP. Usually there's a correlate on history, but not always. And I try to do some detective work during my history taking to figure out any risk factors that could explain someone having CP. So even though this is a non-progressive injury, the clinical course is not static. it's an evolving picture because the child's function will change during growth and their development. And so when I take a history, I'm really trying to pay attention to the birth history. I want to know if there were any possible congenital infections. You remember our torch complex. These infections can go clinically unrecognized in the mother, though. Sometimes if you're evaluating a baby who is born in an underdeveloped country, you worry about gestational toxins. So a bad iodine deficiency can lead to diplegia, or lead or mercury poisoning can lead to quadriplegia. And then out of all the risk factors, as you know, the most common is extreme prematurity these days for CP. So if I'm consulting on a new baby in the NICU, I'm going to comb through the chart and look to see like some of the worrisome factors, like a really low birth weight, less than 1,000 grams, a low APGAR score, less than 3 at 20 minutes out, or a bad head bleed, grade 3 or 4. And then also some of our babies can have prolonged seizures, which can lead to encephalopathy. We know preterm infants have really fragile brain vasculature that can bleed easily. When you're grading IVH, it goes from 1 to 4, and then, so if you have the worst, grade 4, there's enlarged ventricles with blood in the actual brain tissue. And so these cases have a 90% risk of major neurologic sequelae. Bad IVH leads to periventricular leukomalacia, or PBL, which I think more of as scarring. When you have a lack of perfusion to that periventricular area, that will result in like death or loss of brain tissue. And then this region is traversed by descending motor fibers from the cortex. Fibers supplying the lower extremities are more medially located and therefore are more affected in the mild to moderate lesions. But then those are the kids who look to have diplegia. And then when you have increasing severity of the bleed or hypoxic injury, the more lateral fibers get involved and affect the upper extremities. And those are your kids with quadriplegia. During my history taking, if there's no report of extreme prematurity as a risk factor, then I go digging. And then let's say the baby was born term, then I go digging to see if there was some like bad hypoxic ischemic event or maybe a bad kernicterus case. Let's say it was an emergent C-section, there was placental abruption or bad meconium aspiration, nuchal cord, and the baby has a history of being intubated, then that points me more in the direction of an HIE, or hypoxic ischemic encephalopathy. Or usually if I'm seeing a patient and they were coming from an underdeveloped country and there's a history of jaundice, then that alerts me more to maybe a case of bad kernicterus, and the patient sometimes has more of a history of dystonia or a movement disorder. And if there was nothing obvious that went wrong during the actual birth, then I go digging for risk factors that occurred postnatally, affecting the immature brain in that 0 to 3 year period. Sometimes there's a history of a serious bacterial infection or viral infection, or the child suffered from a severe brain injury, from non-accidental trauma, a bad fall, a bad car accident, a near drowning event, or even a stroke. Then there are the babies who are at risk of a heavy metal or organophosphate ingestion because their parents work in the agriculture industry. Once you know what risk factors to ask about, then you can try to get more out of your physical exam. So Dr. Mitsuya already mentioned this in her talk, but we know that most kids with CP end up getting diagnosed between 1 and 2 years of age. But there is, a push to diagnose even earlier these days. So we know that most interventions to influence the corticospinal tracts are most effective early, younger than 2 years of age. In our NICU, there is now a team of providers trying to diagnose as early as 20 weeks, about 5 months post-term. And they're trained on using the Prechtel General Movements Assessment, or GMA. Prechtel was a neurologist who published a lot on the neurologic exam of infants. So we know infants have typical and distinct spontaneous general movements from before birth to right to the 20 weeks post-term. If there's a paucity of the movements or the movements are not complex enough, then you worry. I tried to find a good video for you guys on YouTube, but that was not available. I'm not trained in it yet, but the idea is you take a 3 to 5 minute video of a baby who is nice and awake and calm, not necessarily engaged in a toy or binky or like their parent, and then later on, somebody scores the video. In our NICU, it's the PT who's in the NICU, Michelle, and then our neurologist, Dr. Gardner. So if you see cramped, synchronized general movements, and there's an absence of fidgety movements, that's a good predictor of CP. Whereas just a poor repertoire of general movements and abnormal fidgety movements tend to be associated with just more minor neurological dysfunctions. Once they're a little older, you can use the HINE, or stands for the Hammersmith Infant Neurological Exam. Providers who use this had to go through intense workshops to learn how to perform the assessment. Now, instead of just doing a visual assessment of the video, there's more of a hands-on exam. It's used for patients 2 to 24 months. It assesses cranial nerve function, posture, quality and quantity of movement, muscle tone, reflexes, and reactions. And scores range from 0 to 78, with higher scores indicating better neural performance. In 2017, Novak, based out of Australia et al., published a clinical practice guideline walking you through an algorithm for early diagnosis of CP. So before 5 months corrected age, the GMA is 95 to 98% predictive, really high, and the MRI is 80 to 90% predictive. A HINE score less than 57 at 3 months is 96 predictive, still very high. But when you get a little older, after 5 months, then the values drop a little bit. The HINE is now just 90% predictive. MRI and a different standardized motor assessment using the AIMS or Alberta Infant Motor Scale is 86% predictive. So once you make a diagnosis of CP, however early it is, the family invariably wants to know if their child will walk. The most common thing I tell them is that a positive prognosticator for walking without an assistive device is if their child can sit without support by 2 years. Typically, this happens at 6 months. Another good sign is quadruped crawling on hands and feet by 15 months, and normally this happens at 9 to 10 months. A bad sign is persistence of 3 or more primitive reflexes at 18 to 24 months. And then when they get older, if they're already walking, then families will ask you how long they will walk for, like into adulthood. So there are several factors for that. So marginal ambulators lose function around their teenage years due to progressive orthopedic deformity that's pulling them closer to the floor because they're getting more crouched. Inadequate strength or control to carry their increased mass. We see that a lot. And then other behavioral, social, emotional problems. So now into the classification of CP. When I'm talking about a patient with CP, I like to classify based on the type of movement, the region involved, and then their level of motor function. When classifying based on type of movement, there's 4 types. The most common is spastic, which occurs in greater than 80% of cases. It arises from damage to the cerebral cortex, here in pink, resulting in stiff muscles. Dyskinetic CP is associated with uncontrollable movements, just involuntary movements, and that is associated with damage to the basal ganglia deep brain in green, and that's when you hear terms like chorioathetosis or dystonia. Ataxic CP is associated with damage to the cerebellum in orange, resulting in poor balance and coordination. So these patients have a very wide base gait, truncal sway, makes them look drunk when they're walking. Mixed CP is due to damage to multiple areas of the brain, and mostly it's a mix of spasticity and athetosis. In spastic CP, you can often see it further classified according to the limbs involved. So monoplegia is usually affecting a single limb, usually the arm. Hemiplegia is one side of the body, arm more than leg. Diplegia refers to legs, usually more than the arms, and then quadriplegia is all 4 limbs more severely affected. And then this is the GMFCS system that Dr. Brar already spoke about. So I will say that knowing this, I would diagnose our 2-year-old patient with spastic diplegic CP, GMFCS2, and just now that we went through the classification, you should have a better mental image of him even before meeting him. I mentioned that in terms of the classification by type, more than 80% of the cases of CP are spastic. Here's a reminder of the definition. Most generally, it's an abnormal increase in muscle tone caused by injury of the upper motor neuron pathways regulating muscles. So since we're talking about upper motor neurons, that's referring to our central nervous system, your brain, and spinal cord. Symptoms include velocity-dependent increased resistance to passive stretch, hypertonia, hyperreflexia, clonus, an exaggerated startle or primitive reflexes, pattern movements, loss of selective motor control or weakness. And so this is a kind of busy picture about the pathophysiology. This is kind of going over normal physiology. So you first start at the level of your spinal cord. This picture kind of shows the interplay between your sensory and motor neurons. So when you stretch the patellar tendon, and so normally you would stretch your patellar tendon and get your knee jerk that way. In normal physiology, you hit the patellar tendon with a hammer, or in my case, I just use my fingers, and then that activates your sensory pathways in the red, which then synapses and activates efferent motor neurons, or the alpha motor neuron in blue. And then that goes to activate your agonist and antagonist muscles. Normally, you have an intact brain above to send down inhibitory impulses to the alpha motor neuron to balance out those excitatory sensory signals. But when you have a brain injury, like in CP, the spinal reflex can go haywire. We talked about like this kind of general pattern movements. So usually you see these kids have a flexion synergy. In a patient with spastic quadriplegic CP, you see starting from above down below, shoulders are adducted and internally rotated, elbows are flexed and pronated, wrists are flexed, ulnarly deviated, fingers are flexed and thumbs are fisted. And then in the lower extremities, their hips are flexed, adducted, internally rotated, knees are flexed, ankles are plantar flexed and inverted. Once you have a rehab diagnosis, we try our best to engage the parents in a plan, making sure that they know that the diagnosis is not just an endpoint that stops with this visit. Having rehab early on makes it a start and not a finalizing diagnosis. Rehab can provide the education, give the resources, and do some follow-up. We want to identify a plan and strategies for early intervention and treatment to empower the parents and the child and set the stage for function and activity success. One of the main things that rehab helps with is plugging patients and families into the appropriate outpatient therapy sources for early intervention. In California, we're really lucky to have some good outpatient resources. So usually if you're dealing with someone younger, I will try to refer them to regional center, and then when they get a little older, transition them into California Children's Services Medical Therapy Program, or CCS MTP. After they turn 3. So I staff a lot of the CCS medical therapy units, and I'm most familiar with that system. For the regional center, there's a lot of therapists contracted with them, so it's harder for me to know whom to talk to. And in my opinion, the NTU therapists are really great in providing services to children with chronic disabilities and determining appropriate DME. The MTP has its own medical eligibility criteria, separate from the general CCS program. It's more narrow in scope. And then children with CP make up the majority of the MTP eligible clients, but they open, there's other diagnoses that can be opened. So spina bifida, muscular dystrophy, various neuromuscular or musculoskeletal disorders, and anyone can refer. including hospital and clinic personnel, parents, teachers. Most referrals are requesting for PT and OT. You can also get feeding therapy, but there's not straight speech therapy. I mentioned earlier on how the clinical picture of CP evolves with age. So does the management. During infancy and early childhood, the focus of management is mostly on like motor and cognitive development. So feeding and nutrition, contracture prevention, spasticity management with medications or injections, contracture prevention, adaptive equipment, and then hip and spine surveillance to curb or slow down the progression of those complications. Then as the child enters school age, we encourage families to work with the school on formal cognitive testing and IEP development. For the adolescent and young adult, we focus on social adaptation, including disabled sports programs, vocational rehab assessment, and impaired drivers evaluation. Locally, there's BORP, or Bay Area Outreach and Recreation Program, which is really popular for wheelchair basketball and adaptive cycling. This was a few years ago, but I know one of the MTU supervisors I worked with would lead a course in adaptive sailing in Half Moon Bay. And then one of our senior doctors, Dr. Haining, he used to take his patients up for adaptive skiing into the mountains. Finally, planning the transition to adulthood is critical and daunting. So we try to discuss and develop goals for education, independent living, medical care, and conservatorship if appropriate. Oh, I forgot to mention earlier, Dr. Brar also runs the transition to adult clinic quarterly, which is very neat. Okay, so the management of the child with CP should be carried out as a multidisciplinary team approach. I feel really lucky to get to work so closely with ortho, neurosurge, neurology, nutrition, all the therapy disciplines, social work, and nursing to address all of their physical, medical, and social needs. There are reasons to treat spasticity, and these include trying to reduce pain from spasms, or if there's functional impairment, such as problems with ambulation, wheelchair propulsion, school activities, writing, or computer interface. We also treat for positioning in standing or in the wheelchair or in the bed, and then if there are care issues with hygiene and dressing. Sometimes we can do it for cosmesis, such as decreasing the guard positions or to maybe wean them out of braces, or for deformity with hip subluxation, scoliosis, brace tolerance, or contracture. There's also reasons not to treat spasticity. You want to treat the patient, not the provider. Sometimes you meet a new patient with spasticity and expect to get rid of it, but there can be side effects to treatment. Sometimes you can make them worse. You've heard of some people having maybe useful tone, so they're trying to compensate for weakness. There are some kids who have some standing balance using their knee extensor tone. Some have functional arm positioning using their elbow or shoulder tone. And then sometimes it can help with ADLs, such as toilet transfers and dressing, to help with those standing transfers. And then having some sort of tone can help with muscle bulk and prevent DVTs. When it comes to the actual treatment, you can think of ascending a ladder with therapy being the least invasive, and then each rung being more invasive until you get to neurosurgery, which is usually the option of last resort. Therapies is our default intervention. The main players include PT, OT, and speech. How do you know which therapy is the best, though? There was a systematic review by Morgan et al. In 2016 that looked at 34 studies, 10 of which were randomized controlled trials, and it showed two types of intervention that had large size effect. Those were the ones that promoted child-initiated movement, enrichment, and task-specific training. Therapies can take place in the hospital or clinic, in the classroom, or in the home. Therapists use all sorts of modalities, including casting, compression, constraint, taping, e-stim, vibration, aquatherapy, hippotherapy, and adaptive sports. So here's a baby with right hemiplegic CP and who's undergoing constraint therapy of the stronger arm to try to get more spontaneous use of the more affected arm. If a patient needs bracing for stretching or support, rehab can prescribe it for the orthotist to make. Most commonly used for the lower extremities is the SMO to help with hyperpronation, like Yumi was talking about. And then AFOs we use for toe walking or bad knee hyperextension. For the upper extremity, we commonly prescribe a WHO wrist hand orthosis. And then you can also prescribe separately for wrist and thumb flexion. You'll sometimes see patients with neuromuscular scoliosis in a TLSO. That's your thoracolumbar sacral orthosis. Sometimes we'll just prescribe it for postural support, like for the kids who have truncal hypotonia and they slump too much in their wheelchair. That can sometimes help. The CCS therapy team is the best with figuring out what durable medical equipment is most appropriate for the patients. So I usually fill out a generic prescription, and then they work directly with the patient and the vendor, and the family, of course, to find the exact brand and style that fits into the patient's function and space. Let's say if a patient is not able to stand by 2 years of age, we like to put them in a stander to give them some sort of weight bearing through the legs, give them a different perspective of the world in a more vertical, upright posture. Around 3 years, most of the kids will have outgrown their commercial strollers, so they'll be assessed for a mobility device, usually either an adaptive stroller or a manual wheelchair. And then there's all types of bathing and toileting equipment to help families as well. Rehab does a lot of medication management in patients with overwhelming spasticity in all extremities that's causing pain, discomfort, caregiver difficulty, worsening contractures. Then we'll start medications. You might recognize some of these names. So our go-to medications are usually baclofen, Valium, other benzos like Klonopin, tizanidine, clonidine. They all can cause sedating effects, so we always start low and then titrate to effect. The only med on this list that does not work directly on the nerves is dantrolene, and that works at the level of the muscle. For kids who have certain problem areas that are particularly tight, we can target those muscles with chemodenervation injections, so we don't have to oversedate them with higher doses of the other medications. The most common areas that we inject are the calves for the toe walkers, or the hamstrings for those who are getting more crouched at their knees. And in our practice, we use Botox and Dysport. Sometimes if an AFO or Botox alone is not enough to bring a toe walker's heels down, then we'll use serial casting to address that contracture. We have a casting clinic, and then the doc will supervise, and the orthotech places that hard cast and a rubber shoe for them to walk in. And then we change that out every week. And we typically have them in the cast for 3 weeks total to try to get their heel down and get their dorsiflexion above neutral. So this is a picture that nicely shows the progression of the ankle, starting in plantar flexion and gradually getting to neutral. And then once the patient comes out of that last cast, he transitions into AFOs and then can do a burst of PT for more aggressive stretching and strengthening. Rehab also uses alcohol injections. We're typically targeting the obturator nerves in the groin in cases of severe scissoring. And when the family is reporting that it's really hard to do diapering or hygiene, the alcohol essentially burns the nerve. And the pros include immediate onset. So right when they come out of the OR, you should be able to see the effects. The low cost and longer duration, we say like it can last 9 to 12 months. However, it has to be done under general anesthesia, so that requires more coordination and risk from anesthesia. And it sometimes can cause a burning sensation or hypersensitivity. So for these reasons, a lot of families choose the more popular Botox because of its minimal side effect profile. This is an overlap slide of working closely with our orthopedic surgeons on optimizing the care of our patients with soft tissue or bony bony surgeries, and then the focus on like hip surveillance and surveillance for scoliosis. This is another plug for using the Hip Screen app. Again, I use it every day to check out migration percentage. When I'm out at the MTU, I'll pull it up to kind of remind myself, like based on GMFCS level, how often am I supposed to be recommending x-rays? So back to our patient. In his case, his rehab management included bracing and equipment with hinged AFOs, a reverse walker. We didn't end up using baclofen since his arms were not that affected. He did get Botox to his hamstrings, gastrocs, and posterior tibialis to help straighten his legs out and bring his heels down to the floor. Serial casting helped with contractures at his ankles. And then he just was getting regular monitoring for hip and spine to see if when he would need ortho. Finally, on patients whom you've tried multiple rungs of that treatment ladder without success, then neurosurgery can step in by either placing an intrathecal baclofen pump or doing a selective dorsal rhizotomy. We're going to have a whole panel about the rhizotomy later. So you all know that oral baclofen can cause side effects that might limit its usefulness, such as excessive drowsiness. For patients with overwhelming spasticity and likely some bad dystonia as well, we offer the pump placement. Neurosurgery places these pumps, but then rehab manages the pumps forever after for dose adjustments and refills. It's a huge commitment for families, and you pretty much have to be close enough to a medical center that you can come in to get it refilled every few weeks to months, depending on how high your dose is, how quickly you're burning through the medication. And then after 7 years, you have to get the battery changed out too. So it's a lifelong commitment there. So for patients who are ambulators with higher function, like a GMFCS 1 or 2, and maybe they're having worsening gait issues, they're getting more crouched as they get older, then we offer them the selective dorsal rhizotomy. It's a neurosurgical procedure that selectively divides parts of the dorsal lumbosacral roots of the spinal cord. Here's a picture of the exposed back and the nerve roots before it's dissected into the smaller rootlets. And then by testing and snipping the rootlets, you get significant reduction in spasticity without causing paralysis. We screen everyone through our multidisciplinary spasticity clinic over in Oakland. The best candidates for a rhizotomy typically have spastic diplegic CP from prematurity. And we aim for kids ages 4 to 11, but we definitely can do it for older children. They should be cognitively able to follow directions, sequence tasks, because they're expected to stay on our inpatient rehab unit for 4, 6 weeks, sometimes 8 weeks following the surgery. It's a big hardship for families, obviously, to stay that long. I think if you were to research other centers in the country who do it, the inpatient rehab stay is not as long, but it's because some of those other centers have access to more frequent outpatient therapies for the kids to transition to, like they can get maybe 5 days a week, whereas with what we have available, usually we do the 4 to 8 weeks of inpatient rehab, then they switch to outpatient for 6 months, expecting to get 2 to 3, most of the time it's 2 times a week of therapy. So outside of the standard management, I've talked about there are some cutting edge or emerging interventions. There's robotic assisted therapy for various functional goals that are emerging, such as the robotic trunk support trainer for independent sitting, and then robot assisted gait training for motor control. Our rehab department in Oakland has invested a lot of money for the state-of-the-art robotics, including the exoskeletal robotic ambulation device put out by this company called Exo Bionics in the Bay Area. But you have to be at least 5 feet tall to use it. So for the smaller population, we purchased this Trexo robotic gait trainer. And then for the upper extremities, we bought the robotic suite from Tyro Motion, which our OTs will use to work with their patients. I think that's my last one. I think questions will be later on then.
Actually,
Oh, is it now? Okay. Thank you.